Hello. Hi, I'm Dr. Kushagra. I'm one of the senior residents in Fortis Memorial Hospital and Research Institute, Gurgaon. Uh, and today we're going to talk about the role of activated charcoal in poisoning. The question being, what is activated charcoal? So, it's nothing but charcoal that has been treated with oxygen at very high temperatures to make it porous, and so that it changes its internal structure and it reduces its size, thereby increasing its surface area. Shouldn't be confused with your normal charcoal briquettes that are used in your grill or barbecue. While both being the same products, the ones which we use for your grills, they contain substances that can be harmful or even toxic to humans. How does it work? So it usually absorbs the ingested toxins within the gastrointestinal system, preventing the systemic absorption for that toxin. The downside being that it only absorbs toxins that are in dissolved liquid phase via direct contact. Where does it work? So orally administered activated charcoal does not get absorbed through the gastrointestinal lumen and acts within the GI tract in its unchanged form. Ingested toxins come in contact with activated charcoal if the drug has not been absorbed yet from the GI lumen or via recirculation of the toxin into the gut lumen by either enterohepatic or enteric recirculation, and it's either absorbed via active secretion or it's passively diffused onto the activated charcoal. So the adsorption is based on the equilibrium or the availability of the free toxin and the activated charcoal toxin complex. So if the free toxin is more than the activated charcoal, desorption may occur. However, in adequate doses, when the equilibrium shifts towards the activated charcoal toxin complex, the role is beneficial. This attempt to shift the equilibrium in favor of activated charcoal toxin complexes is the rationale for dosing activated charcoal to charcoal toxin ratio of 10:1, and it usually absorbs toxins in their non-ionized form. Polar water-soluble molecules are less likely to be absorbed, so it best absorbs non-polar, poorly water-soluble organic toxins. So if you break it down, the activated charcoal has three basic pores. It has a macropore, a mesopore, and a micropore. So organic toxins usually break down into particles which are less than or which vary between 2 to 15 microns or nanometers, which, you know, wherein the bit of using activated charcoal comes into play. What are the indications? So what factors that increase the appropriateness of a single dose activated charcoal? We read about single dose and multi-dose activated charcoal in the later slides. So when you're anticipating a serious toxicity, when the patient is alert, cooperative, when the ingestion is recent, the airway is intact, we don't have a specific antidote, the charcoal mass is more than the drug mass, approximately 40:1. The substance is known to adsorb to activated charcoal, and when there is no intestinal obstruction. What are the contraindications? You don't have a protected way. The patient has a low GCS. Hydrocarbons, need to visualize upper GI tract, risk of GI hemorrhage, and an uncooperative patient. So, again, it's repeating the same thing that we just read. Uh, SDAC can be useful if you're anticipating serious toxicity, ingestion within an hour. Beneficial up to 4 hours if you're suspecting a very large ingestion or ingestion of delayed release drugs and ingesting substances with anticholinergic or opioid properties that decrease intestinal motility. In alert and cooperative patients, airway and reflexes are intact, and ingestions of toxins without specific antidotes. MDAC can be considered in life-threatening ingestions of specific drugs like carbamazepine, dapsone, lamivudine, phenobarbital, quinine, and theophylline. There have been a few studies on uh, drugs like lamotrigine, chloroquine, and caffeine. Hatanaka et al. Reported 2 cases of lamotrigine overdose, where MDAC reduced its intrahepatic recirculation. Storman S. et al. Reported on a suicidal patient who had ingested large dose of chloroquine and diazepam. The patient got better with treatment of activated charcoal, vasopressors, and diazepam and survived. Azimpur K. and Subramaniam reported a patient who had consumed caffeine, where the patient received large doses of MDAC and beta blockers and survived. Can be used in gluten ingestion with celiac disease, but there is a lack of clinical evidence. So again, it's up to the clinician. The optimal dosing is always unknown for a single dose activated charcoal. If you know the amount of toxin ingested, the dose of 10 is to 1, the ratio of 10 is to 1 can be used. However, the ratio may be impractical if the dose is unknown. So if the dose is unknown, the SDAC dosing can be started from 1 gram per kilogram of body weight, or using a simplified age-based dose scheme where for adults it's 50 to 100 grams, for infants younger than 1 year it's 10 to 25 grams, for children between 2 to 12 years it's 25 to 50 grams, and children older than 12 years we have to follow the adult dosing guideline. MDAC refers to administration of 2 or more sequential doses of activated charcoal for enhanced elimination of ingested toxin. So it appears to prevent the ongoing absorption of the drug remaining in the GI tract and to enhance the elimination via the enterohepatic or enteroenteric recirculation. So the dosing strategies may vary. The initial dose might be a 10 is to 1 if the toxin dose is known, or a kilogram per kg of body weight. Intervals of 1 to 6 hours in adults, with doses varying from 0.25 to 0.5 grams per kilogram. Some cases have employed the continuous administration of activated charcoal through an NG tube. A simplified approach would be basically a loading dose of 25 to 100 grams followed by 10 to 25 grams every 2 to 4 hours via the NG tube. For children, an initial dose for MDAC, an initial of 0.5 to 1 grams per kg body weight, followed by a 0.125 to 0.25 grams per kg between every 1 to 4 hours for 4 hours. In adults, 50 grams followed by 12.5 grams per hour every 1 to 4 hours, or we rather follow the 10 to 25 grams every 2 to 4 hours. Now, what are the adverse effects? Pulmonary aspiration and aspiration pneumonitis being the concerning risk factors for administration of activated charcoal. Aspiration from emesis and misplaced nasogastric tubes for activated charcoal administration can lead to severe respiratory compromise and even death. In patients with depressed level of consciousness, we must consider the risk to benefit ratio of administrating the activated charcoal before intubating the patient. Emesis occurs with rapid administration of activated charcoal, and the risk of emesis increases when sorbitol is added. While emesis is a common adverse effect, more significant gastrointestinal complications such as bowel obstructions have been reported, where patients have being given MDAC, or patients who have a pre-existing motility disorder are receiving opioids and antimuscarinic drugs. What are the contraindications? Six major contraindications can be seen: unprotected airway, high risk of aspiration pneumonitis, threat of GI perforation, endoscopy is to be done, which might hamper the visualization, presence of an intestinal obstruction, and when activated charcoal is known to not meaningfully act on substances like metals, acids, alkalis, electrolytes, and alcohols. Recent advances show that a study done in Iraq and was published in the Journal of Medical Sciences show recent developments in the use of activated charcoal. And there are basically multiple areas where it can be used, starting from the substances that can be sorry, my bad, uh, from amphetamines, ACE inhibitors, antidepressants, except lithium because it falls into the heavy metal category, anti-epileptics, antihistaminics, beta blockers, barbiturates, NSAIDs, diuretics, especially furosemide, antidiabetics, paracetamol to theophylline. So toxins that are absorbed on activated charcoal with specific names like death cap, aconite, couget, fly agaric, tobacco, ricin, strychnine, taxanes, and even digitalis for that matter. Now, what are the factors to consider in deciding whether the patient requires activated charcoal or not? Number one being, does it bind to the charcoal? Drugs which do not bind to charcoal are lithium, iron, and therefore should not be given. Was the drug ingested within an hour? For most drugs, activated charcoal is indicated within 1 hour of ingestion only. Is the drug likely to stay in the stomach for a prolonged time beyond 1 hour post ingestion? Then consider using MDAC. Some drugs will stay in the stomach for upper intestinal tract for a prolonged time. In overdoses that involve drugs with these properties, charcoal should be considered even if ingestion occurred more than an hour ago. You can start with a single dose administration regime, either 10:1 or 1 gram per kilogram, and then consider if the drug has a low pass from the GI tract, consider giving MDAC. Examples of such drugs would be medications like extended release formulations, entry-coated medications, opioids, and anticholic medications that delay gastric emptying. Is the patient protecting the airway? Aspiration pneumonitis is the most common complication of activated charcoal. So if you suspect that the patient will not be able to protect their airways, avoid using activated charcoal. What are the points to remember? Now, I think we're going to end the discussion in some time. Remember to never give activated charcoal or anything else to an unconscious person. Remember that activated charcoal will not work in cases of poisoning by strong acids or alkalis. Foods tend to impair charcoal's absorption. Increase oral dosage of charcoal if a meal was recently eaten. Despite our best efforts to keep our children from harm, sometimes they manage to ingest drugs, household chemicals, and insecticides. Now that you know the benefits of activated charcoal, keep a supply handy in powder or capsule or tablet form. Thank you so much.